On behalf of Commissioner Ray Crean and paramedics across the state, in the short time that we have together, I just want to run you through what a typical day in ambulance might look like to focus our minds to the winter that we're about to enter. So it's not unusual in health or indeed in emergency services to look around at what the rest of the world is doing and consider whether we might apply those lessons there. And so in that respect, we're no different. We've done an environmental scan of what's working in other jurisdictions, and we had a look across at the UK at what they were doing to try and manage demand, and we think that this might have some application in this jurisdiction this winter. But in terms of what does winter look like, well, what does a normal day in ambulance look like? And just some interesting facts and figures to sort of set the scene for what a day or a year will look like. Nearly 1 million emergency calls to emergency 000. Australia has had a universal emergency call service since 1961, and we know that that is a very easy thing for the community to access, and in fact every year we'll have a number of small children that will successfully navigate 000 on the phone to summon assistance for someone that they care about and to receive advice and support whilst we mobilise an ambulance response. Over 1 million, in fact nearly 1.2 million responses across the state of New South Wales. Always more responses than calls received because, as you'll see shortly, a number of the incidents that we attend require multiple resources to be mobilised. And perhaps a little surprisingly, because most of the community would think that the ambulance turns up, treats the patient and transports them by default to an emergency department, just over 500,000 patients transported last financial year to emergency departments across the state. So what does that mean, to put it into context that we can understand, because they're big figures when you take them across the whole year? Well, it means that our emergency call takers will answer an emergency 000 call about once every 34 seconds. So if I can manage to stick to time with you this morning, that means that we'll have 40 or 50 000 calls answered in the time of any of these presentations. And we'll mount a response about once every 27 seconds to those, whether those are primary responders or more traditional stretcher ambulance crews. What does that mean in terms of the state? Well, as one of the largest jurisdictions, it won't surprise you that there's a significant number of emergency 000 calls across the system. Some 44% going to police, who traditionally have fielded the majority of calls, for the primary reason that if the Telstra emergency call operator is not able to distinguish which emergency service is required, it will default to the police. Some 7% of emergency 000 calls to our colleagues in Fire Rescue New South Wales, but the lion's share now coming to ambulance, and this is a trend. So not only are we a large jurisdiction, we're a busy jurisdiction in terms of the volume that is coming in through the phone lines. And in fact, although a little difficult to read, the first 4 months of 2015 have showed that that trend is continuing, and we continue to take just a shade under half of all emergency 000 calls across the state. So what does a day in New South Wales Ambulance look like? Well, it looks something like this if it's an average day, and of course we all know that average is a theoretical construct developed by statisticians because you can never find a day in the 365 days of the year that looks exactly like this. But somewhere in the state today, we will deal with a cardiac or respiratory arrest on average once an hour. If the weather is fine, we'll deal with about 74 motor vehicle crashes. Clearly, if the weather is like we've experienced in recent weeks, that number can increase substantially. And we'll deal with 13 or more directly related pregnancy or childbirth cases, and 1 or 2 of those every day. There'll be 1 patient when the ambulance crew arrives at the scene, but by the time they arrive at your emergency department or maternity ward, there may well be 2 patients on board the vehicle. Again, in terms of what the community understands, it's probably the bottom part of the slide that most people would associate or in fact see the vision of ambulance crews in action. So there's no shortage of vision about attending stabbings or gunshots, animal bites, the occasional electrocution. But as you can see here, those sorts of jobs really are in the minority of what we do. And the vast bulk of our work falls to falls, breathing problems, chest pain and other medically related conditions. And of course, for the clinicians in the room, you'll understand that breathing problem can be life-threatening or it can be nothing at all, as can chest pain, as can falls. So there's a significant diversity within those patient cohorts that we need to triage not only at the time of call, but by the attending ambulance paramedics and in making transport decisions about whether an emergency department is in fact the right place for that patient to go to. So this would be a traditional view of an ambulance. I think if you ask most community members what's an ambulance, they would tell you that it's some form of light truck or van. It has 2 ambulance paramedics on board, whether they're professional salaried staff or in our regional areas, whether they might be volunteer staff or whether they might be supported by community first responders. But the reality, of course, is somewhat different from that, because this vehicle is an ambulance, this vehicle is an ambulance, as is this, for very small patients, as paediatric response unit. Ambulances that fly, both rotary wing and fixed wing, to combat some of the challenges of distance that we have across this very large jurisdiction. Special response units that move either specially trained paramedics and or equipment to a variety of scenes. Rapid responders, where we want to navigate traffic or put a clinician next to the patient in the shortest possible time frame. Likewise, our motorcycles, currently operating in the Sydney CBD, but we're currently exploring ways that we might use them to a greater extent across the metropolitan landscape in particular. It's entirely appropriate in winter to have this slide here for how we mount a response to the snow. We know that between skiers and snowboarders, and appreciating there's always a divide in the room, but both get hurt, both require ambulance treatment and assistance as we enter this time of year. In fact, the reality is that anywhere that you can go in New South Wales as a member of the public, somewhere that New South Wales Ambulance needs to be able to mount a response, because invariably people don't get hurt in the convenient places next to arterial roads, but in more difficult places. In fact, this is an ambulance to mount a response over the back end of the snowfields, where if we don't get this right, not only is the patient at risk, but so too are the responders, because of the incredibly adverse environment that they'll be operating within and the fact that they might be out there for some considerable amount of time. And just like we have traditional views of what an ambulance vehicle is, I think this might well be a traditional or stereotypical view of what ambulance paramedics are. 2 paramedics operating together as a crew with a patient and transporting a patient to a destination. But the reality is this is an ambulance paramedic, in this case in a chemical suit, to deal with hazardous incidents. We work very closely with our colleagues in emergency services to make sure that our response is a true multi-agency response. We hang helicopters, paramedics beneath helicopters to access patients in difficult terrain. We put them on ropes and send them over cliffs to follow the people that were on the ropes that went over the cliffs that then got hurt. We crawl them into all sorts of tight spaces, because that's where the people of New South Wales sometimes go and end up needing our assistance. As we've seen in the Hunter New England period with the East Coast Low and the storms, we also put them in swift water to perform water rescue. We put them on boats to mount marine responses, including significant distances offshore. And increasingly we're doing a lot of work with law enforcement and other Commonwealth agencies in the tactical medicine space to make sure that truly we can minimise the response time to critically ill patients in their time of need. So why do I tell you all of that? Because I think it provides an important backdrop or context to what the ambulance service is doing every day. And as we've just heard from Dr Shepherd, as we're probably on the start of an up curve into winter, then we can expect that the response demands from the community will continue to grow. And in fact, we know that winter can be one of the busiest periods in terms of demands upon our services. So ambulance has embarked on a bit of a journey, and one of the key components of that journey is that we're no longer just a transport-based service. The default or perhaps traditional view of an ambulance service that answers the phone, dispatches a transport-capable vehicle to the scene, provides a level of treatment or intervention, and then transports the patient by default to an emergency department is really something that we're challenging and putting a lot of time and effort into. And as Luke mentioned in his opening remarks, we're starting to see now for 2 consecutive quarters that whilst the overall number of presentations to public emergency departments continue to increase quarter on quarter, the number of patients taken in by the ambulance service is modestly decreasing. So very much this concept of take the healthcare to the patient. And if necessary, this is not about total ED avoidance. This is not about not saying we're not going to transport any patients. It's about transporting the right patients because the ED is the place that they really need their ongoing care. But there's a whole range of strategies that we're implementing, and this really does go to the heart of tailoring solutions for local operating context. And broadly, these fit under the banner of integrated care strategies, and some of them may well be familiar to you because we're working with you and your teams on implementing these. Some of them may be new to you. If any of them interest you, then anyone in a white shirt today is fair game. So get to them before they get to the muffin table at morning tea and ask them the questions about something that maybe you haven't heard about that might have application in your part of the world. Aged care, we know that we've all heard about, you know, the ageing demographic and the challenges that brings about, and comorbidities and the mix of chronic disease and acute presentations. So as an ambulance service, we're looking very closely at what we do in that space and how we provide the best care to those patients, and how, particularly if you're elderly and particularly if you're in some form of supported care arrangement, perhaps dragging you out of there in the middle of a cold, blustery winter's night to go down to the ED to spend many hours is actually not in your best interest if there are alternate referral pathways that we can arrange for you, or alternate care providers that can provide some supported assistance in that residential facility. Authorised care plans are an important part of what we're doing across the state. Ambulance has traditionally been a protocol-based, form of treatment, but we know that one size doesn't fit all. We know that every patient has their own unique needs, and increasingly we're partnering with specialists and other allied health professionals to make sure that we tailor the treatment plan to the specific, not only medical circumstance, but often social circumstance that the patient will find themselves in. This also has an important component to it in terms of end-of-life care and respecting wishes of individuals who don't necessarily, again, in the middle of the night, want to be dragged down to the local emergency department in the final hours or the final phase or chapter of their life. So it's about how do we provide, how do we identify those networks in advance and then connect the people that need to be involved in the conversation. So an ambulance may still well be called to those sorts of patients, but it can provide supportive care and it can work as part of a broader multidisciplinary team. And again, we don't have this default option that the ED is the only place that you can go to die. Our extended care paramedics are doing an increasing amount of work, and we're looking at strategies to target that particular clinical skill set to the right patient. So things like basic prescribing rights, suturing of basic wounds and referral to other healthcare professionals becomes an important component of their practice. By default, an extended care paramedic doesn't have a transport-capable vehicle or a traditional transport vehicle with a stretcher on board. So this is about how do we maximise their use and connect them with the patients to whom they can really make quite a difference. I've mentioned alternative referral pathways. On the central coast of New South Wales, we've had a very successful proof of concept where an ambulance crew will attend and assess the patient and then make a determination and have a conversation with the patient and their primary care provider about whether the ED really is the best place for them to go, or whether a visit to the local doctor's surgery in fact might not be a better option for their primary presenting condition. This is important because ambulance paramedics will often see patients in a range of circumstances, and their primary healthcare provider can be none the wiser until the next time that the patient attends the doctor's surgery or has an appointment. So the person that is providing continual care is somewhat out of the loop. So any connection that we can make in that space becomes really quite important. In Western Sydney, we've had a proof of concept to look at the way that we respond to mental health patients, how we might be able to identify them in advance at time of call, and how we partner an extended care paramedic with a mental health nurse and determine what really is the best thing for this patient. Because as I'm sure many in this audience will be aware, a busy, noisy emergency department is often the very worst place to put a mental health patient, particularly if they're there primarily for the purpose of medical clearance and then you're going to move them to a mental health ward for definitive treatment anyway. So anything that we can do to fast track that system and safely and appropriately clear them and get them to a point of definitive care is not only of primary benefit to that patient, but also has a wider system benefit in terms of less ED crowding, and we know that these patients can be very resource intensive in terms of staff. Paramedic Connect in the regional areas of New South Wales provides an opportunity for ambulance to actually not be the responder, but to be involved more in that preparedness or prevention space. So connecting paramedics with people in the community before they have an acute crisis that triggers an emergency 000 call with some basic ongoing health monitoring or health care. So simple things, just like we see at disasters where it's clean water and food. Well, in this setting, it's about monitoring blood pressure and monitoring the management of diabetes and those conditions before they present to become some form of acute health crisis that requires a higher level of intervention. And of course, I couldn't not mention our frequent user management program. There are a small number of patients who occupy large amounts of all of our time, and we all know that they don't always have medical conditions. There are a wide range of complex social and other circumstances, but these people do need help. At 3 o'clock in the morning, one of the few services that is guaranteed to be open is the 000 network, and of course the doors of your emergency department. So again, by taking a much more proactive, multidisciplinary approach early on, we try and identify what really is the primary presenting issue or set of issues for these patients and intervene. And we've had some quite remarkable success in reducing the number of presentations for these people, many of whom you would have seen on a regular basis, sometimes up to daily, to have the whole assessment, treatment, discharge cycle, only to repeat that cycle the next day, or on some extreme occasions later that same day. So in late 2014, Commissioner Crean and New South Wales Ambulance Management launched Today is the Day We Make Tomorrow Different. And this is really about a whole broad set of strategies across the state that can be applied to local circumstance. It empowers our local management teams to look at a menu or a suite of options, to look at what their patient cohorts require, and to then tailor some strategies and implement a lot of them as partnerships in the integrated care space with your LHDs. In the Sydney metropolitan area, we now work quite closely with 2 bulk billing GP services. Our paramedics can assess that the patient does not require transport to an emergency department, and in fact the most appropriate response, particularly out of hours on public holidays or weekends, might be a bulk billing GP to attend the residents and then to provide a link or feedback or referral back to the GP that normally has ongoing care for that patient. So the challenge of winter, we're just about to launch one of our components of the winter campaign is your urgency and emergency, because I'm sure it won't surprise the people that work in or around EDs that you'll have a whole spectrum of presentations, and ambulance is no different in that regard. An ability to discriminate a life-threatening condition, particularly when we get to periods of decreased resource availability, becomes quite important. And it also becomes quite important as part of a broader educational landscape that there are a whole range of services that are available, but the real challenge, I think, for all of us in ambulance and health is to make the right connections between the patient and their particular circumstance, their knowledge of what services are available, and then assist them to increase health literacy and to be able to access the most appropriate service for their condition in a safe and appropriate way. So Luke mentioned the media and the challenges that sometimes we all have, but one of the significant challenges that we face across the system, particularly when it gets busy, is not actually the abuse that ambulance paramedics might face face-to-face or in a physical confrontation, but in a verbal setting. And our call takers really are sort of the hidden face of ambulance behind the scenes, who will run from call to call to call and can literally go from providing CPR advice to a highly distressed family member or bystander, to delivering a baby, to copying a mouthful of abuse about the call. So part of the link to our winter community education campaign is not only the Is Your Urgency and Emergency campaign, but also building an awareness in the community about the role the call taker plays, how it's absolutely critical the information that they collect is, and that abusing a call taker really just serves to delay the response. It certainly doesn't serve to expedite getting that big white van outside, your address. So winter this year, winter's a fairly significant concern for ambulance because the pressure it will place upon the resources and the whole system. And so our winter planning actually commenced in October 2014 last year, at the end of last winter. And it's almost a continual planning cycle of thinking about what worked well, what didn't work so well, and what can we improve, what can we change. And clearly these forums provide a really important component of that for that. So we have a winter plan, and again, Luke mentioned that most of us have got winter plans, but the challenge is, where do the winter plans connect? So where are the references in the ambulance plan to the LHDs and who we're going to talk to when the brown stuff hits the fan and starts to get sprayed around the room? Do you know who to talk to in ambulance and access our health relationship managers or our duty operations managers? And then when it all gets really difficult, how do we escalate, bearing in mind that whilst we're both facing similar challenges, it's actually a common good that we're working for, and that's the patients either in the system or that are about to enter the system that will often bring us together in conversation. So we have a range of strategies and action plans and engagement sessions. If you were playing management word bingo, you'd probably get quite a few hits on this slide. And of course, it's not about what's in the plan and the dust that it collects on the shelf. It's about what really happens when the rubber hits the road. And at times of high stress and high workload, we have to interact and make sometimes difficult decisions about where we're going to send limited resources. So we monitor performance carefully, and for the ambulance people in the room, I think we're almost immune to it. We're completely desensitised to the fact that our first performance standard as you enter that emergency 000 network is that we will attempt on 90% of occasions to answer your call in 10 seconds or less. And we know that our performance is sitting at around the 87–88% at the moment, so it's not where we would like it to be. But if you've ever run 000, then even a second can seem like a lifetime. So for our call takers, we measure performance in seconds. Generally in the metropolitan context, we measure the mobilisation and response time of ambulance crews in the space of minutes, and we aim to resolve from start to finish an episode of patient care with ambulance in hours. Of course, for our regional colleagues, that extends a little bit further due to some of the challenges of distance. But it really is a very high tempo, highly pressured environment, and a lot of the staff that are working hardest on that are behind the scenes or on the end of a phone. So we monitor performance really to within an inch of its life. We monitor how long it takes us to answer the calls. We monitor how many keystrokes the call taker takes. We monitor the time to mobilise an ambulance crew. And we look at where the system is at. And this is just a snapshot of our Sydney Control Centre dashboard. And it's not just about hospital block. I think a really important thing to understand is that whilst hospital block is a critically important issue for ambulance and for the broader system, there are a whole range of other things, including just incoming call volume, that will relate to how our system performs under stress. So it doesn't have to be a really bad winter's day with high rates of influenza-like illness. We can get a surge of calls at any time, not just in winter, in any season, at any day of the week and any time of the day. So it's not just Friday and Saturday nights the system feels the pressure. It can be 7 a.m. on a Wednesday morning when there's an avalanche of calls for the community. So we monitor this quite closely, and then we take an organisational posture in response to what the indicators are telling us about the amount of work that's in the system. We have three statuses in that. So status 0 for us would be normal operations. And remember, normal operations that I mentioned is mounting a response somewhere in the state about every 26 seconds. So as we move through status 1, 2 and 3, we actually have more demand than that. There's more requirement to mount a response in shorter and shorter timeframes. So when we hit status 1, although it's the first stage, we've already had a significant compromise to our emergency response capability. We're talking about a decreased number of ambulances being available in the system, and what that likely means is that the ambulance running to the next emergency will have to run from further away. That means that it will take longer to get there. If you have a life-threatening condition, the difference in that running time or that response time could make a substantial contribution to your outcome. At status 2, we're really under a significant amount of system-wide stress. So status 2 is bad. Status 2 is a place we aim not to get to very quickly, but reach on an increasing number of occasions. And status 3, I'm told, we've never reached, and certainly that would be our aim for this winter and any winter into the future. Because at status 3, we're actually talking about implementation of things like AMPlan, health plan, and providing advice across the whole system that basically there is no capacity. The well is empty, and the reality is that for our call takers and dispatchers, they will have a significant amount of additional stress because on their screens will be a number of flashing lines with timers, and those timers will just keep extending because there's nothing left in the system to send those patients. If you have a non-urgent condition, you can probably afford to wait a little bit longer for an ambulance response. But if you're compromised, if you're unconscious, if your airway is occluded, or in fact if you're suffering a life-threatening condition where time means the difference, then you don't want to be that flashing line on a dispatcher's screen when there are no ambulances there left to send. So I'll just briefly outline for you what do we do as an organisation. Well, the first thing when we hit status 1 is what we call a local escalation trigger. And this is when we'll be starting to talk to you, and one of the proposals going into this winter and forward is that we actually communicate much more broadly when we're at status 1. So a lot of people in ambulance are aware when we hit status 1, but perhaps not more broadly the system, and I think that's an important gap that we've got in our communication to understand that we really are under a significant amount of stress at this point. And like a lot of things, and particularly relevant to issues of patient flow, if you don't catch it as it starts to build, that blockage just tends to get bigger and bigger and bigger, and the crisis point, you might argue, is somewhat inevitable. So early intervention really is important to us. We'll be responding people to emergency departments. We'll certainly be talking with emergency departments, and we'll be looking at our organisational posture at a number of things that we can do. And we will do everything that we can to assist to free up the number of resources and get back to status 0 as quickly as possible. If we hit status 2, in the old terminology for us now, divisional trigger, we're talking about pouring more resources into the system. We're talking about starting shifts early. We're talking about asking people not to go home on time. We're talking about standing to an increasing number of managers across the system, right up to and including state headquarters. And we're talking about bringing on extra crews. So this is saying that our normal resourcing levels are just not coping, and we really need to surge resources into the system whilst we work on a number of strategies with you to increase ambulance availability. This is the point that we will start to not accept routine admissions. Obviously that's a very careful determination that needs to be made, but the reality is this falls back to the basic principle of triage. We have to serve, and our whole organisational posture needs to be around that life-threatening emergency, and less urgent cases, unfortunately, in this sort of circumstance, may be waiting a considerable amount of time before we mount an ambulance response, or we may be starting to have conversations that in fact we're not mounting an ambulance response. So one component, I said it's not all about access block or ramping or whatever terminology you like to use. It isn't all about that, but we can't deny that that is an important component of the system. And I just want to provide a brief case example of how that manifests at a system-wide level right down to an individual patient. Because the reality is this is the emergency department for New South Wales Ambulance. You can't open a surge bed in the back of an ambulance. You can't squeeze too many more patients into the back of that vehicle. So once our system is stretched, once our capacity and our capability is challenged, unless we're able to bring additional ambulances into the system or additional staff into the system, the reality is we actually have very limited surge capability, particularly in the transport phase, if we're seeing a cohort of patients that need to move through to an emergency department. So this is a de-identified but real case from recent history. It's an emergency 000 call to a 26-year-old lady, and this is the report the call taker gets at the time of call. The patient is conscious, they are breathing, they're having a severe asthma attack, and they've commenced with their medications as part of their asthma action plan. There are 3 ambulances in close proximity to this patient at the time of call. First one has been at an ED for 47 minutes, second one has been there for 40 minutes, and the third has been there for 27 minutes. The first unit is assigned at 13:08, or 8 minutes past 1 in the afternoon. It's a single responder, so it's not a transport-capable ambulance. It's a single responder, and we start their response 29 kilometres away from that lady, who at the time of call is conscious and breathing. We respond a second unit at 1:27 p.m, and that's a unit where we leave a patient and stretcher at an ED, and we dispatch the crew because we know we only have one set of hands on this case, and this lady is likely to be extremely unwell. And the first unit arrives at the patient's side at 13:33, some 25 minutes after the call. The second unit arrives 3 minutes later, 28 minutes after the call. For the patient that was conscious, breathing and administering her own medications at the time of call is found in cardiac arrest. She has no pulse, no respirations, fixed dilated pupils, and the patient's husband, who was the caller to emergency 000, is performing CPR. Sadly, this was the outcome for this patient. When our system is under stress, whilst it's a system-wide stress, there are significant outcomes for individual patients in the system who can wait too long, if they have a life-threatening emergency, for an ambulance response to get there. And even though we might mount the ambulance response immediately, if you're as sick as this lady was, 29 kilometres is an awful long way to travel, lights and sirens across this city. If we look at the response time of the ambulance that cleared the emergency department, it was 9 minutes away from the scene, not 29 kilometres. Now, we don't know absolutely, because that's speculative, about whether the outcome for this particular patient would have been different. But I think there's enough information in the literature and in our own clinical experience to know that if you're critically ill, you don't want to be waiting a long time for an ambulance response to be mounted. In fact, you're probably down at the seconds and minutes end of the timescale rather than the minutes and hours end of the timescale in terms of how we put paramedics beside the patient to treat the particular circumstance that they're facing. So this really is the challenge, and I like Dr. Vicky Shepherd's slide about the elephant, because I think in the ambulance context this is probably the elephant in the room for us to reflect on and to continue conversations on. If we've got a deteriorating patient outside of the health system with no clinician at their side, with the only support being an emergency 000 call taker providing verbal advice over the phone, to a potentially panicked, distressed or distraught relative, friend or bystander, where is the greater need in the system at that time? I'm not pretending this is easy. It's far from easy, which is why it continues to challenge all of us. But if we go right back to the first introduction week for a student paramedic, we would talk to them about triage. And we would say sometimes there's more than you can possibly do as an individual clinician. There might even be more than you can do as a system or a set of resources on a scene. And in those circumstances, you need to identify where the care that you will provide will have the greatest impact. And what I'm suggesting to you today is that the deteriorating patient outside of the health system is the greatest priority if they have a life-threatening condition. And as challenging and confronting as that is for all of us, we need to think long and hard about how we deal with patients that are on ambulance stretchers in or near emergency departments, sometimes in tertiary referral hospitals, with dozens, scores, or potentially hundreds of medically trained professionals around that could assist in the care of the patients in the department, but also the patients that are outside the system that are about to enter the system. There's no end of high-profile cases for ambulance and the health system where the ambulance response time will come into focus, and this is just one from relatively recent times, where community, media and indeed government will ask the question, why did it take so long to put health professionals beside a patient. So here's a quiz question for you. How many ambulances are on duty in the Greater Metropolitan Sydney today? The 6 options. There's no phone a friend, there's no lifeline, there's no 50-50. Is it 123, 107, 103, or all the way down to 82? Anyone want to be brave and take a guess? White shirts are automatically disqualified and not to participate in the quiz. Although if the white shirts don't know the answer, perhaps we better have a chat over morning tea. Well, at 10 a.m. this morning there was 107 ambulances on duty. By 11 a.m. there's 123. 100 at 7 p.m. tonight. 98 by the time we hit 10 p.m. tonight. 82 at midnight and for the small hours overnight. And 103 by the time we get back to 7 o'clock tomorrow morning. So we already profile the demand by adjusting our roster projections and the amount of resources that are available to fit what is a fairly traditional demand curve, not only for ambulance services but also for emergency departments, when we've got people awake and moving through the system. But the question wasn't how many ambulances are there in metropolitan Sydney, because that will vary by time of day. The question was how many ambulances are in metropolitan Sydney now that could respond to a life-threatening emergency. And 2 weeks ago, Commissioner Crean took a snapshot at 10 a.m. on a Tuesday morning, and this was the answer. Only 1 in 5, on average, of the rostered emergency ambulances in the system are actually available for the next life-threatening emergency response. So the remaining 80 plus vehicles will be on their way to an emergency, already assigned. They'll be at the scene providing care or assessment. Where appropriate, they'll be transporting patients to emergency departments, and of course some of them will be at emergency departments in the process of, or waiting to commence the process of, transfer of care so they can be freed up for the next emergency. So about 1 in 5 are available. Now, they could be anywhere in the city, because surges in demand means that whilst there might be 22 ambulances in the greater metropolitan area, there might be none in the eastern suburbs or the CBD. In fact, the closest ambulance to us at the moment could be running from the western suburbs north across the Sydney Harbour Bridge, or coming up from the south. So I said we do just on average 1 cardiac arrest a day. If this was a traditional hospital environment, this would be a fairly standard thing that most people in the room would be familiar with. 1 patient in cardiac arrest will take anywhere between 6 or 8 health professionals. If we translated that to pre-hospital care, that would take 4 emergency ambulances out of the system. Now, the reality is that we don't manage them in exactly the same way as they're managed in hospital. Whilst the principles of treatment and the core components of treatment are the same, the average pre-hospital cardiac arrest will be managed with 4 clinicians, not 8. And they will also have the challenge of dealing with that patient in whatever their circumstance of collapse was, and preparing that patient to movement and ultimately, obviously, transport in this instance through to an emergency department. So it's not just the number of incidents or the number of patients, it's also the complexity of the patients that we face that really provide a challenge for us. This is another one from relatively recent times. This is an extraordinarily lucky gentleman who had a cardiac arrest in a bell tower of a church. All the links in the chain of survival came together on the day for this gentleman. He got prompt recognition of the fact that it was a life-threatening emergency, prompt and effective CPR, quick ambulance response time, and ultimately extrication and transport to an emergency department. So this is what it looks like when it works well and right, and there are available resources in the system to contribute to positive patient outcomes. I won't dwell too long on this, but suffice to say that at any point in the system, there's a whole range of resources in a whole different set of states. And this is an ambulance arrivals board. And we can look at each individual case in isolation and we can say, well, they haven't been here that long. You know, we're only just approaching the 30-minute mark, or we're only just over the 30-minute mark because it's 41 minutes. And that's a completely accurate and relevant assessment for that ambulance crew. But there's only about 123 rostered in the greater metropolitan area, and if it's an average day, there's only about 22 available for response. So this just isn't about unload the patient at the 29.5-minute mark. This is about unload the patient as soon as it's practical and safe to transfer care, so that we can get that ambulance crew back into the system and back on the road and ready for the next response. And certainly as we start to get into some quite extended delays, we need to be looking at the whole system-wide effect, and the Commissioner's phrase of an avalanche is a collection of snowflakes seems most apt here. Because I think we can all defend on an individual level where things are at, but when we step back and we look at the system level of the impact that that's having, that's really where we'll make the most difference. So this particular slide, just a snapshot in time, any of the white lines are up to 45 minutes, the pink ones are up to 1.5 hours, and so on. That's just a system-wide snapshot of where things can be at any particular point in time. So demand surge management, just quickly, status 2, we're starting to empty our state headquarters at status 2. We're starting to say to most of the managers that are sitting in this room, stop what you're doing, the brief can wait. You need to get ready and to be able to mount a response as quickly and as rapidly as possible. Luke mentioned immediate transfer of care and talk about difficult issues. Well, this definitely falls in the difficult basket. What do we do when there's a life-threatening emergency within stone's throw of an ambulance that is at an emergency department? That but for the opportunity to safely transfer or transition care, they could be far and away the closest resource to a life-threatening emergency. Well, what we're proposing is to use a 10-minute rule. If it is going to take us longer than 10 minutes to get to a life-threatening emergency, and we have an ambulance within a 10-minute response or drive time of that incident, we're saying we really need to be doing everything that we can, and it is a we, everything that we can to free up that ambulance and get them to the life-threatening emergency. So what we're proposing is to identify a nominated ITOC phone number and to call and say, we need that ambulance free, we need it now, because we know that that ambulance needs to move rapidly towards a life-threatening emergency. And we don't have minutes and hours to escalate this. We don't have time to involve multiple layers of management and executive. This is a very raw, very direct ambulance dispatcher or ambulance supervisor talking to the person that you nominate in your emergency department that has the authority to make the decision, that understands the clinical consequences for a patient that is unattended in the community, so that we can mount a rapid ambulance response. What we're asking for is this: an immediate transfer of the patient to hospital staff and a release of the ambulance crew. Because if it's a true life-threatening emergency, the ambulance crew might not need to make the bed and put the sheet on and do hospital corners. What they need is the AED, in all likelihood, with a charged battery. They need an airway kit. They need their drug kit. They need to be able to get beside the patient who is unattended in the community and provide a level of care whilst we deal with the complex logistics of backing up that response and determining the most appropriate pathway for that patient. So in closing, I'll just come back to, we all have our challenges and we all have a range of different emergency departments with different stresses and pressures across the system, and New South Wales Ambulance certainly recognises that. And all we ask in return is that you recognise that our emergency departments have exactly the same limitations in terms of capacity or capability that yours do, and that we are all challenged together at the times when demand exceeds supply, and how we posture ourselves to mount an effective and appropriate response to a life-threatening emergency in the community. Thank you very much.